Now, what can you utilize a soft tissue laser for in your practice? Now, why do people want to buy a soft tissue laser? They say, I don't know what practice implications can it be used. Lot of things you can use laser for, right? From hemostasis to therapeutic procedures. One by one, I can give you an example of the clinical picture which I have been documenting my cases. This is gingival recontouring. The patient came to us with an anesthetic looking porcelain fused to metal crowns. We have used and contoured the gingiva and to reduce the amount of swelling, and then a metal free crowns were given to the patient. For periodontal tissue management and conservative surgeries, it is highly recommended. Now, these are diode laser example, like 8-10 nanometers at 1 watt I have used to contour the gingiva. I have done nothing. I have just done the contouring of the gingiva, gingivoplasty, and you can just have an aesthetic contouring and it heals up within 1 or 2 days without any anesthesia. Crown lengthening. Before crown lengthening, you can just make sure that can your biologic width be maintained? Will your attached gingiva can be preserved? Is the tooth restorable? Will there be a loss of support of the adjacent teeth? Apart from crown lengthening, you can also use diode lasers to gain subgingival caries, expose margin, explore fractures, develop a form of restoration, increasing surface area for retention, and smile can also be enhanced by manipulation of your gingival contour. Now, if you look at this case, we have done a crown lengthening for the patient because there were uneven length of maxillary central incisors. Follow a rule of golden proportion. A surgical guide or a stent can be determined for an apical extent. Suppose if you are a new operator and if you are not sure of doing a crown lengthening for the patient, to ask your lab to fabricate a surgical stent. A surgical stent can be prepared and then you can mark upon it and then you can perform your conservative gingivoplasty or crown lengthening procedure. Usually a 45-degree angle chamfer is gingival chamfer is given with a laser tip to create it. Lower wattage and power is desirable. Always start with lower power and wattage in a sweeping motion when you have to sculpture the gingival margin, something like this. Or something like this. This is an immediate chairside procedure. I use it regularly. You don't have to be worried of your bleeding, or don't have to call the patient again after 3-4 days to check the healing. You can immediately do a troughing along with your crown lengthening and take impressions or scans. This is a case with a 940 nanometer laser in a continuous mode, which is used to recontour the gingiva, lengthen the gingiva, and hemostasis. Being an endodontist, I usually treat badly decayed teeth or grossly decayed teeth. So I have exposed the margin, then did a root canal for the patient. It was something like this. Then did a post and a core buildup, and then your crowns can be used. You can also use it for ortho-induced gingival hyperplasia. Your cut can be more precise and visible because during ortho treatment, it's a long span of orthodontic treatment which a patient undergoes. You will see gingival inflammation very, very commonly. So you have to decrease the pathogen reduction. Once you are doing a gingival hyperplasia or you are doing a removal of excessive gingival overgrowth, you are automatically reducing the pathogen because your residual bacteria are evaporated, denatured, and dehydrated. This is a case of pyogenic granuloma, and the downtime which I took to do it was 5 minutes with no scarring, no suture, no pain, no heat, and swelling. Healing took between 3 to 5 days. Coming to frenectomy, just make sure before frenectomy you check the gingival biotip type, the tension of the frena. At least 2 mm of keratinized attached gingiva should be present. A complete removal of frenum insertion which is fibrous and close to gingival margin, resulting in traction, can be dealt with frenectomy. These are the cases. This is a thin fiber type. This is a thick type. You can do it. You can move the laser tip unidirectionally by pulling the lid. One pass should be enough, something like this. The power setting can be 3 to 4 watt continuous wave if you are using a surgical fiber tip between 400 to 600 micrometer. A contact mode, you have to use a local anesthesia, and within 5 minutes you are done. The wavelengths which you can use is 810, 940, 970. Now visible wavelengths are also available in the market, like 445, 450, which you can also use between 1 to 2.5 watts. Very light depth and working strokes are available. Coming to your frenectomy, that is laser tongue tie removal, also known as ankyloglossia. You can also do it with laser, diode lasers. However, erbium family is more desirable, but I have a diode family, so I do it with diode also. And downtime is usually 10 minutes. There is no need of sutures, dressing, and healing takes place in 5 to 7 days. These are adult patients. This is a neonate which we excise, and it's a developmental anomaly characterized by thick lingual frenum, which limits the movement of the tongue. You can also do a gum peeling, depigmentation, or also commonly known as gum whitening in your dental practices. When as a laser cuts, that's a diode laser, it precisely vaporizes, which is known as ablation, and it simultaneously coagulates. Now you can mostly find it in smokers or patient under medications such as anti-malarial drugs, antidepressants, minocycline, and hormonal disorders, or it is a physiological pigmentation also. Now, by 2 modes you can do it. By one, you can do it with a diode laser. One, you can do it with an erbium family. In a diode laser, you have to remove the tissue with photothermal energy, sometimes referred to as vaporization. Where in erbium family, you do a laser peel. Laser peel is similar to your chemical peel which you done on the skin. The laser energy is absorbed into the tissue, and then it starts coagulating with the subsurface layer. And once the patient comes to you after a few days, you will find there will be a new gingival epithelium formed. So that's why it's known as a laser peel. Now this is a case of a diode laser which was done by a gum depigmentation. This was a full mouth rehab case. This is a depigmentation. After depigmentation, we also did the treatment for gingival enlargement for the same. And this is done by an erbium family. So you can see the difference. Once you use with the diode, immediately something speckled tissue feeling will be there, whereas in erbium family, after 3 to 5 days, a fresh gingival epithelium is seen. This is done by a diode on the left side, and on the right side also by a diode, that is an 810 nanometers. Something like this. This is the diode, and you just peeling the at a very low power and a voltage. You keep peeling and you keep rubbing with a wet gauze. Lip depigmentation can also be done with 810 nanometers in a non-ablative manner, in a non-contact mode, not in a contact mode. Coming to non-surgical laser-assisted periodontal treatment, you can also clean the deep pockets, perio pockets, so that no bleeding on probing, the bleeding on probing gets off, the patient does not complain of bad breath, and gingival epithelium becomes also healthy. Something like this you have to do. You take the laser fiber tip. This is a diode laser with a fiber tip, and then you with the pocket encircling, you just do it in a 1 watt non-initiated dip. Total time usually takes place between 5 to 10 minutes. This is for maxillary. Take out the fiber tip very gently from the tissue. Insert it very gently because it's a glass tip. Something like this. This is also known as the periodontal curettage or a laser bacterial reduction with a diode. This is a case of a non-surgical periodontal treatment done at our clinic. You can also perform excisional or incisional biopsies for the patient. Pedunculated lesions can be excised by lasing the base of the lesion. You can hold the lesion with the tooth forceps on the top, pull it to the side on the top of the wet gauze to prevent charring of the normal skin. You can always use the gauze, wet gauze, as dry gauze can catch fire. You wipe off the vaporized lesion with the wet gauze. Always make sure to dry the area or wipe it with the water with the dry gauze. Coagulate the bleeding points, if any, but by defocusing the laser beam. Now, this patient came to us with a tongue fibroma just because of the oral hygiene and the sharp lower mandibular teeth he had. He was uninterested in any other treatments and he was only interested in taking out the fibroma. So we took out the fibroma. You can use it 810 or 980 nanometers also. Till the time I never had visible wavelengths in my practice, I always had 980 and 810. You can use 2 watt. There is no scarring. Whole fibroma can be taken out in toto. And then you can defocus your laser beam. That means you can use it in non-contact mode and you can just heal up. This is known as something known as laser bandage. And after laser bandage, after 5 days, you see healing, super healing. Same for your corns on your feet. This is a skin or a tissue tag or a corn removed by a diode laser. Then this is pyogenic granuloma removed by a diode laser. Excision of small gingival growths can also be removed. Now this is a tongue lip fibroma by lip biting from a very small of a teenage kid. I've removed it and then you create a char or a bandage and then the patient did not turn up. But when we video called on and we followed up the patient on a video call, so he showed me his lip that this is something like this. This is tongue fibroma in the circumferential area. Now this is, can you see some mistake here? It's excessively charred because I was using higher power laser. So this became more charred. Same here happened, but this was a bandage created, but here it charred. So you should avoid doing that. However, it healed well. It did not have scar on tongue because of the high vascularity of the tongue. It did not have scarring, but you should be careful to give the tissue as thermal relaxation. Coming to photodynamic therapy, which you can use in endo, can be used from 635 to 950 nanometers. And both in vitro and in vivo studies have demonstrated the ability of photoactivated disinfection to kill photosynthesized oral bacteria such as Enterococcus faecalis, which minimizes root canal failures. The power setting can be 1 watt, 810, 940 nanometers. Fiber can be adjusted to your root canal length. And you can achieve bactericidal reduction in main root canal, bactericidal reduction in deeper dentinal canals, destruction of microbial biofilm, access to difficult anatomical areas, fistula treatment, inflammation reduction, pulpotomy and apexectomy can be performed only with erbium family or a heart tissue family, and advantages in previously unsuccessful treated cases, that is re-RCT cases. Then with diode lasers, you can also perform what is known as photobiomodulation or low-level laser therapy. Low-level laser therapy is also known as soft laser or low-intensity laser, whereas the therapy has been referred to as biostimulation or biomodulation, or other terms which I have given are also used. They generally operate in visible or infrared spectrum between 600 to 900 nanometers. Suitable therapeutic energies range from 1 to 10 joule per point. Now, when the laser light you are using between whatever wavelengths in 600 to 900 nanometers, you are delivering the laser light to the tissue in a contact mode, that you're touching the tissue. Once the laser light enters the cell, now there is something known as powerhouse of the cell, which is mitochondria. Now the powerhouse of the cell has a chromophore, which is known as cytochrome C oxidase. Once your laser light is absorbed in the mitochondria with the help of cytochrome C oxidase, then the activity of mitochondria is increased. Now, because of increase in enzymatic activity, you release ATP, which increases the cell ability to fight infection and accelerate the healing process. Then ROS, that is reactive oxygen species, which positively impacts your cellular repair and healing. NO, that is nitric oxide, increases circulation because it's a potent vasodilator, decreases inflammation and enhances your transport of oxygen and immune cells throughout the tissue. As a result, the three molecules are heightened, and that's why your biological effects are seen. Now, where can we use your photobiomodulation? Can be or low-level laser therapy in herpetic lesion in a non-contact mode, post-COVID ulcerations with a non-contact mode, aphthous ulcers, then your herpetic ulcerations, you can use it in a non-contact mode, something like this. 1 watt, very low watt, non-initiated tip, 5 days. Usually it takes maximum 5 days to have complete healing without any antibiotics, without any non-steroidal anti-inflammatory drugs. You can also use your low-level laser therapy for pre-malignant lesion. For soft tissue injuries, you can see a cut on the tip, be irradiated with a low-level handpiece, and then a ulceration, a complete healing of the lower lip was seen without any scarring. For facial pains, papilloma, hemangioma, lymphangioma, mucoceles, herpetic lesions, xerostomia, and even for TMJ disorders. You can also do laser-assisted in-office whitening with both soft tissue lasers and hard tissue lasers. You need to properly isolate your sensitive areas like lips, buccal mucosa, cheeks, so that you avoid burning. Or you can use long braided cotton rolls and folded gauze may be used. Then you can have to use resin barrier material to protect your or liquid dam from papilla to papilla, so that you protect the underlying gingival epithelium. After that, you cure your resin barrier material. This is how your barrier seal looks like before whitening or before bleaching. 25 to 40% concentration hydrogen peroxide gels are usually applied. Now, when you are applying heat with diode laser, temperature elevation of usually 10 degree is reported, so that your hydrogen peroxide decomposes at a speed, at a double amount of speed, doubling. For laser activated bleaching, your gel should have a proper photocatalyst, which is an absorber, so that it matches the wavelength or the spectrum of the light used to accelerate the gel. It is always important to use the appropriate bleaching gel with a particular laser wavelength in order to have high absorption laser energy inside the gel. You can also use laser in a defocus on a non-contact mode in a burning mouth syndrome or after post-extraction. Or also for endodontics, antimicrobial photodynamic therapy for your periodontal pockets, for your nerve repair, for your hyposalivations, for non-neoplastic proliferative lesions, for implantology, and for hyposalivation that I've already mentioned. Now, this is an implant exposure done with a diode laser. You can see the amount of char I've deposited on the tissue. Whereas if you look at one of the implant exposure, there was a clean cut. The second one was because I was using a glass fiber hot tip and I did not clean the tip properly, or maybe the tip was burned too much. So it led to a little amount of char. Now, there are 9 essentials to your laser safety. When you are using any high power laser, make sure you have laser safety in your dental office or clinic or hospital where you're working, because laser beams get wider with distance. There is divergence, and the more most of the laser beams can enter eye pupils and can lead to optical hazards also. So you have to be careful. Now, we are using a laser which is mostly class 3B or class 4. That is more than 500 milliwatt or 0.5 watt output power, which can be termed as extremely hazardous. So what are the critical laser safety elements for both safety and compliance? A laser safety officer is a must. Now these are all the documentation which I have done because it's already in the records in the literature, but I'll give you an overview. A laser safety officer is a person who has a responsibility for the management of risk and the authority to ensure compliance with all the applicable standards and rules. The person should be competent to assess all systems and validate the knowledge and skills of all personnel involved in laser practice. Although the vast majority of LSOs work in that role only part-time, someone has to bear the responsibility for laser safety. The LSO is a person any regulatory inspector is going to ask and see and is expected to perform all the laser safety officer duties. The best laser safety officer is someone who helps come up with solutions and suggestions to assist the user in their efforts. This can include better IVR, improved detection devices, enclosure options. Critical responsibilities of all the LSOs are make sure laser safety training is relevant to actual laser work and risk, assist in laser IVR selection when IVR is needed, review hazards and see effective control measures are in place and functional, review any required documentation. For a part-time LSO to be effective, management must be supportive and allow them the time to do their job. Now you have to cover all the bases of laser safety training. Like you have a separate area where you are keeping the laser devices. You have a different area for working. You do the documentation with proper both trainer and trainee. And this is important and can be augmented by your ongoing mentoring also. This is also termed as institutional training. This is usually in more simplified words, I'll say training your staff. If you train your staff, you are more safe and secure rather than not training and taking it casually. Evaluate, analyze, and mitigate the hazards. From a safety department perspective, all accidents are preventable. However, you cannot eliminate all the risks. The LSO is tasked with finding a balance between the two philosophies. In industry, laser safety is almost always engineered into the product, whereas in medicine, laser safety is dependent on a checklist system. Fabrication approaches laser safety somewhere in between two poles. Now, in research such as lab, all bets are off because beam manipulation is routine activity rather than a rarity. Like where you are doing more research, they are already very equipped with laser safety devices. Whereas compared to your clinical practice, if we are working on the same dental chair or the dental practice, we don't have a caution signal, we don't have a warning signal, or we don't have blinds, or we don't have glass barriers. So you have to mitigate those changes in your practice once you incorporate lasers. That's why beam manipulation, you can have a beam detection, beam blocks, perimeter guards, good work practices, and IVR so that you critically reduce your risk. In addition, user must be expected to follow correct safety protocols. Each time someone peeks under their IVR, nothing happens. It just reinforces to the bad practice. Now, what I've seen with people using lasers, you have a glasses protective IVR. Now, they always want to see it with a bare eye. They are using the glasses here, but they're always kept on their head. And they want to see the laser beam through the naked eye. Don't do that. Once or twice, you might not get hurt. But believe me, third or the fourth time, you will get a corneal burn or you will get a retinal damage. So don't play with it. On the other hand, the LSO needs to remember that very restrictive controls will drive users to find workarounds. It is important to find balance between safety and risk. Safety through cooperation needs to be the mantra in your practice. Now you have to wear appropriate laser protective gear. While laser IVR is the last line of the defense, the people think it's the first line of protection. Now, what I've seen is they keep interchanging company laser. If you are using 2 to 3 laser devices in your practice, all have a separate IVR. So please use that. It is not like one company has specified, so you will be using it for all the laser devices. No. Frame comfort can also be an issue for you. Like if you see this has to be snug fit with proper attire, head caps and glasses with the patient optical protective IVR also. Now, if you have to wear an IVR and optical density of 7 or greater, IVR should be replaced with remote viewing or motorized mounts. Now, you have to be very particular that you are using a laser wavelength matching optical density glasses. So make sure that's very important part. Control your axis of the laser beam. Like the laser which we are using is usually class 4. So the first option is a non-defeatable system. Like you close the door, you are there and your assistant is there. That's it. Entry where door is open, the laser falls onto the safe condition. So it is very difficult. The next option is interlock system. Now only the suppose if you are working with 2 or 3 assistants, the second assistant only can enter through a swipe card or a channeling lock, so that when he or she enters, you know that they are coming. So before that, you can just instruct them that the laser device is on and you should not enter without the optical glasses. And last and the broadest option is administrative approach. This can be a simple sign to an electronic lock which keeps people out, so that you have something written on it that laser is on, caution or something, yellow sign, something like that, danger laser radiation. You have to post these warning signs so that these signs inform people what hazard they may face going forward, including the optical density and wavelength, and what protection may be needed. While warning signs are informative, we all know they become invisible over time. The purpose of warning signs is to mark the boundary of safe from non-safe, termed as nominal hazard zone or nominal ocular hazard distance. What about illuminated signs? The major issue with these are soon majority are connected to laser power supply, meaning as soon as the laser is turned on, the light comes on. But just because a system is on doesn't mean the beam is inaccessible and therefore harmful. The beam could be blocked, such as during warm-up period. Hence, in many cases, illuminated sign is on all the time and they become as invisible as warning signs on the door. Despite their limitations, their operation should be a part of laser safety training. Two alternatives to connecting the power supply are to tie to a shutter or have a multi-status sign. The incorporation of flat scenes into interlock system allows visualization of not only laser status but also active location in the room. Another option is scroll illuminated lights, where the message moves across the face of the sign or the sign blinks. Their activity produces greater chance of catching one's attention and being read. In hospitals, you've seen this danger laser radiation, but the disadvantage is as soon as your machine is connected to a power supply, it stays on. Maybe patients or the patient's guardians or whoever are accompanying the patient, they overlook these signs. So it's always better that they have a blinking sign along with it to keep it in a protective safety mode. Complete all your paperwork before starting. The standard operating procedures have been a part of laser standard for many years. Today, the SOP can take several forms, from a traditional SOP outlining hazards and mitigation steps to risk analysis document. Training documentation. You have to keep records of non-documented, not done. It's still true today when the first is said. Now, there are still people using laser without any documentation, which is very wrong. Audits, laser standard also call for periodic audits to determine if control measures are used and still functional. Other records that I told you, user signatures, retraining your records, interlock tests, and the list goes on as you fine tune your staff with your elements of the program. Drop the medical surveillance. long ingrained in laser safety program is the baseline eye exam, which actually has not been a part of laser safety standard since 2007. That's right, it's no longer required. An eye exam is only required when injury is suspected. Some firms have dropped the baseline while others have kept it, falsely thinking it gives some liability protection, or afraid removal will show a lesser commitment to safety. Although this medical surveillance is not important, but as a part of spectacle wearer and an optical lenses wearer, I go for an eye examination myself every year, because I use laser almost daily in my practice. It's a chairside practice for us. As you use an aeroter, I use a laser. Prepare for accident, but hope they never happen. An item, many are not prepared for what do if incident occurs. Do people know what to report an incident, how to react? Is there a medical response plan? Who will perform a follow-up investigation? These all are important questions, and like insurance, we hope we never have to use them, but we want to have a policy in our pocket if needed. Safety is everyone's responsibility. So knowledge of laser science, if you have knowledge of laser science, then your ability to perform risk assessment develops. When your ability to perform risk assessment develops, you develop appropriate safety policies. Then automatically, after development of your safety policies, whether you are working in hospital, clinics, or any offices, you have a safer staff, and automatically a safer patient care is given.